Good morning, everybody. Assalamualaikum, and welcome to the next edition of the breakfast at UMHealth. So today we have a lovely session that we've organized for you in association with the World Cancer Day, where the campaign, the 3-year campaign has started on the 4th of February this year with the tagline, Close the Cancer Gap. So this is a 3-year campaign in the first year, to realize what the problems are in the gaps of cancer care. And the next year would be uniting our voices and taking action. And the following year in 2024 would be Together We Challenge Those in Power. So these are the World Cancer Day campaign that will take place over the next 3 years. So today we have a lovely panel of speakers and panelists to discuss one of the areas of cancer care gaps that's really prevalent in Malaysia, which is return to work. Many women and men who have cancer find themselves in a position where they are not able to work during treatments and sometimes have to stop their work and are not able to find good employment after that. So today, let me introduce you to the speakers and the panelists. So later we can slowly go through this focus on return to work. So the first speaker we have is Dr. Tania Islam. She's an epidemiologist and researcher in the Department of Surgery, and her area of interest is in cancer survivorship, and she is the project coordinator of the Malaysia Breast Cancer Survivorship Study that she will give us more details about, with preliminary findings from the MyBCC study. Over to you, Dr. Tania.
Good morning to all the panelists and audience. I'm Tania. Thank you for inviting me here, Prof. Today, actually, I'm going to talk about the preliminary findings from the Malaysian Breast Cancer Survivorship Cohort study, which is also known as MyBCC study. MyBCC is actually a prospective cohort study which is designed to recruit 1,000 newly diagnosed breast cancer patients in UMMC. We have started our recruitment since 2012. We include the patients who are newly diagnosed with primary breast cancer, age 18 years above, and within 4 months of diagnosis, and the stage should be within 0 to stage 4. And we only recruit patients who are Malaysian and able to converse either in Malay, English, or Mandarin or Tamil. We exclude the patient with prior history of any other cancer or patient are bedridden. So MyBCC actually is a longitudinal study. We got the 6 subsection of the study, in which we collect the information of the patient nutritional status, anthropometric measurement, the physical activity, the complementary alternative medicine information, then the financial access to healthcare and work-related information, psychosocial support, costing, and other than these 6, we actually collect the patient blood and the other findings, and also the socio-demographic and clinical features. And the final outcome of our study is actually the overall survival and the quality of life. So once the patient comes to the UMMC clinic, we screen the patient according to the eligibility, and then the eligible patients are recruited in the surgery and oncology department. Once they are consented, they are interviewed at the baseline, and we also collect at this time point blood and tissue, and then their anthropometric measurement also taken. The following follow-up were done at 6-month time point, 1 year, 3 year, and 5-year time point. So until December 2021, actually we able to recruit 1,000 participants, and currently we have 699 patients at 6 months, and 662 at 1 year, and 49 and 301 at 3 year and 5 year time point. We also collected the blood of the patient, and we have the food diary of the patient at 1 year, 3 year, and 5 year time point. So our response rate is 65%, which was 78 before. During COVID, actually the rate reduced. As today's focus is on return to work, today I'm going to share one of our pilot study which we have done in 2018 and 19 on return to work among breast cancer survivors. At that time point, actually in our baseline, we have 579 participants. Out of 579, 225 participants were working at that time, which means 40% of our participants were working. And we followed them for 1 year time point, and we able to recruit them, achieve their information of 129 participants. The other 96 were some were defaulted or not done or pending recruitment. And we found that out of 129, actually 59 of our survivors returned to their work 1 year after the diagnosis. That is 45.7% of our participants actually returned to work. So the baseline characteristics of our preliminary 225 working patients were 40% of them were Malay and 45% of them were Chinese, and majority of them were either government working in the government agency or in the public sector. Most of the participants were working either sedentary work or lightweight work. Only in our participants, 4% of the 1.8% participants were working in heavyweight work at that time. And majority of the participants were working full-time with fixed monthly salary. And we found that majority of our participants' income was more than 1,500 at that time. So this is the work status of 129 working women during 1 year follow-up period, which we found that the 59 participants who returned to work after 1 year, 37% of them are government working in the government agency, and around 60% who were working in the private sector. When we see the characteristics of the 59 participants who returned to work, we found that 83% actually returned to the same employer, same title, and the same job. And 89% of them were actually working full-time with fixed monthly salary. And also the majority of them were working sedentary work and lightweight work. And there was no heavyweight worker who returned to their work. And the sick leave they have taken, 26% of them actually taken sick leave of 7 to 12 months, and the mean sick leave they have taken was 6.3 months. When we asked them about the constraint in their work, we found that many of them told that they need rest in between the tasks, they are getting forgetful, or they have some emotional and sensitive issues, or no confidence. When they were asked about the motivating factors in return to work, they replied that the wage, 66.1% actually replied that the salary or wage is the factors that motivating them. Other than that, the regaining to normal life, spend time, the important factors that motivate them to return to work. When we ask them like important difficulties that they have faced in returning to their work, they said like some of them say work stress and emotional problem, and other problem like physical problem are the problem they face during return to their work. Among our participants who return to work, 36.4% actually think that they need rehabilitation in return to work. And when we ask them that what aspect of rehabilitation might help you to return to work, some of their response were strength and endurance, the memory and motivational confidence and other factors are they expect from the rehabilitation that might help them in their return to work. We also asked them the reason for not returning to work. The 42 survivors, they mentioned that some of them mentioned they need rest, they are sick, maybe the old age, and their family members does not allow them to work. And some of them also think that they are not physically fit. So in conclusion, for our pilot study, we found that 54% of our previously employed breast cancer survivors did not return to work after 12 months of post-diagnosis. And there is a substantial economical impact for family and society, we believe. And we think that the policy of prescribing long-term sick leave should be reconsidered, and the barrier and facilitators should be aware for more effective delivering of occupational rehabilitation for cancer survivors. Actually, this is our pilot study. We plan next one is to do a big study capturing 1 year, 3 year, and 5 year time point of our patient return to work and what are the factors that can affect their return to work. Other than the return to work, I want to share some of the findings, most of which are already published, of our breast cancer survivors. We actually got 2 published papers of the diet and the anthropometric measurement section. Alarmingly, we found that 60% of our participants are actually overweight and obese. Even after 3 years, the overweight obesity trend doesn't decline. It actually significantly increased from 1 year to 3 year time point. And we found there is suboptimal delivery intake of both 1 year and 3 year post-diagnosis, whereas the fiber, calcium, and carbohydrate protein intake is suboptimal, but fat intake is more. Another paper published in 2018 for the complementary alternative medicine, we found that 34.8% of our survivors are actually CAM user, and the dietary supplement was the major CAM used by them. And then there were 2 papers published by our psychosocial group. We found that among our survivors, the anxiety is the more significant than the actually depression, and passive social support is an important factor that can actually improve the quality of life. There is another ongoing study which shows us there is a declining trend of physical activity and quality of life of our patient at 1 year and 3 year time point. Also, just now I share with you the return to work rate, which is 45% at 1 year follow-up time point. These are the references for my studies. And I want to thank my MyBCC study team and UMMC breast cancer research team. Thank you. Over to you, Prof.
Thank you, Tania. Yeah, thanks, Tania. So I think we have heard a little bit of data, local data on return to work. And I think for most of the audience would be very interested to know, is there really a return to work program that's catered to cancer patients? Well, I think for most of the practicing doctors, they don't know about any return to work programs that's available. So the next speaker will help to clarify this issue. So Associate Professor Mazlina Mazlan is the current head of the Rehab Medicine Department in the University of Faculty of Medicine. She's the chair of the National Conjoint Board for Rehab Medicine Specialty Training, and her area of specialty is actually neuro and cognitive rehabilitation. So without further ado, Prof. Mazlina, over to you.
Thank you, Prof. Aisha. Let me just share my slide first. All right. Thank you for inviting me to be part of the team today. All right, this is just going to be an overview of return to work program in UMMC, not specifically for just the cancer survivors. I think it is very important that we know that such program and such practice and services is actually available in UMMC. And at this point of time, it is still, we're still not covering the whole, the whole spectrum of all the people with disabilities and illness in UMMC. But we are evolving. We hope that we can improve this service and include everyone who needs the service. Yeah. Okay, so this is just, I think, about another 10 to 15 minutes, just talk about what Return to Work is and what is the program in UMMC and how we think we can close the gap for the cancer survivors to return to work. First and foremost, return to work just means that you return or you go back to a paid employment. Either you work, you self-work. I mean, you in your own work, or you work with an agency or companies. And for in UMMC, when we have this program Return to Work, we actually include Return to Studies as well. I mean, Return to Universities, because we don't have a separate entity for Return to Universities. We all lump it together under the Return to Work. But majority of the patients are actually those who are really employed. So there are advantages and benefits of return to work. I mean, we heard the previous speaker, Dr. Tania, mention, why the survivors want to return to work. First and foremost, really, is to improve the well-being, quality of life. Because when you go back to work, you feel that you are actively participating in the society. So we have, I think, all of us in the last 2 years have experienced, when you have to work from home, it's also not the same, but at least you're doing something rather than coop up at home. So that's why number 6, one of the advantage and benefit of return to work is to reduce the secondary disability from unemployment. When you don't have anything to do, when you were active before, you start to feel depressed, you start to have deconditioning, you don't have mood to go exercise, you don't have to do, a lot of things, just physical and mental disadvantages when you don't go to work and or do something. Number 3 here is to increase the sense of self-worth. And when you go back to work, you focus on your abilities rather than on what you cannot do. Right, so it just steer your mind away from all the, from the illness that you're having, and it also helps you to achieve the financial independence, which is really important. So you have your own money, and it can contribute to the country's economy, your family as well. And it is also an essential part of comprehensive rehabilitation program. In our program, our rehabilitation program, we do not stop at patient be able to, feed themselves. They can walk, they can transfer, they can go, they can make their own meal, but we actually extend to community, and it's not complete until we make sure that all our patients go back to the previous work, or like in the cases now, go back to university or studying. So that is an essential part, and normally towards the end part of the comprehensive rehabilitation program. Okay, so there are many factors affecting return to work, which also has been highlighted by Dr. Tania just now, but you have to remember that there are many factors that can affect this return to work. For example, the external pressure, the employee characteristic themselves, the patient themselves, which will include communication with the employer. So employer are very important. The employee perception, this is what I think just now in the previous studies, the result, we can see what their perception is, why they don't feel that they want to return to work. But the other main thing is this: ongoing treatment, existing complications, and they may also have problems with claim and MC, that is also a big issue when they want to consider returning to work. Workplace culture plays a very big role. So we didn't realize it because different workplace has different cultures. Some cultures, some will allow MC, some are very flexible with working, working hours, working shift, but other workplace may have a very strict culture that you have to come in at 8, not even 8:01, and you have to go back, probably they expect you to go back late. So this workplace culture is something that we need to address, because I think from the employee side, a point of view is also one thing that we can address with them. But I think this is also a very big thing to address, the workplace culture and the employer factors. Okay, so so that's about return to work, and what is a program in UMMC? It's available in UMMC, and the main player is actually from the occupational therapists who are specialized in return to work and occupational health. The clients or the patients who are suitable patients that can enter into this program, return to work program, are those basically who has been working before. Either they are recovering from workplace injuries, or they are recovering from chronic and long-term illness, still working pre-injury. But we also have this another section, another group of patients who were unemployed before, but they wish to return to work. So we also accept this kind of patient to the return to work program in MMC, as long as they want to return to work. And what is the safe return to work? It means that we want to ensure that those patients or our clients will return to work in a timely manner. And safe meaning that there is a gradual increment in the duration of work and also in the intensity of work. Because whenever you have an illness, you will have problem with you need to recover slowly. So the gradual increment intensity is very important to ensure that they are safe to return to work, and they will have to undergo a lot of stages, for example, work conditioning, work hardening, health promotion, education, which are provided by our occupational therapists who are specialized in return to work. And we in UMMC have this sort of like an early structured approach, which means that we will do the early evaluation and treatment because it can lead to better outcome and faster return to work. That is our aim. Because when you are medically stable, when you feel that you should return to work, you should return to work early and not delay the return to work process. So the first step in the return to work process in UMMC is we start in the acute ward. When the doctors are referred a patient for rehabilitation, at the back of our mind, we will always look into what the patient's work as, what is the previous job, what the current job, so that we can initiate and maintain this close liaison with the employer. Because normally when we take them over, we transfer the patients from the acute ward to the rehab ward or to our care. We always try to consider the duration of the paid MC as much as possible, because there are certain work who, like in government servant, you are allowed like 3 months, where you get full pay. But there are certain companies, private companies, they only allow probably about a month. So we have to consider that. And whenever we want to start rehabilitation, we will look into, because we don't want them to lose this salary, to be unpaid while they're on MC. So that is also one thing that we want to get the information early on. The patient's employment for ease of rehab, planning, job scope, and funding. Funding is also another important issue, whether their company will fund them for rehabilitation, because it includes the return to work stage as well. So we want to also ensure good communication between parties, which means that the treating clinicians, employer and employee. The employee will not mention this, but the patients, employee and patient, I will use it interchangeably. The patient are actually worried about their job whenever they are struck with any illness. And it's true enough with cancer as well. Because they always think that, oh dear, then my boss will, probably just sack me, or, I'll get, removed from my job, how I'm gonna pay, and they are actually worried, but there are a lot more things that they are worried, but that is actually at the back of their mind, which not everybody will address this issue early on. So it's also very important, the recovery process. And we also try to initiate SOCSO equally portal. I think this is a lot more to do with implants and all the instruments or equipments needed for patients who is under SOCSO. So this is part of our early structured approach in PPUM. And so another early structured approach is that whilst we have all this information, we try to maintain that communication alliance with the employer. We also try as much as possible to transfer the patients directly from the acute ward to the rehabilitation ward. Now we have few beds previously, but I think at the current state, we have 38 beds, but we are not using it fully yet. But we hope to utilize all the beds in the future. What we'll do is that so that we enroll them in the intensive rehab program, and when suitable, when they are okay, they're medically stable, they can improve or be independent or slightly independent in their day-to-day activities, we will start to look into this gradual addition of the related physical and cognitive assessment that's related to their job. Because sometimes, what you do every day does not translate to what you need to do at work. So we start to look at this component when they are ready towards the tail end or middle of the acute rehab program in our ward. And we will discuss with the therapists, discuss with the team to add on the job-related tasks in their rehabilitation program, their day-to-day rehab program and activities in the ward. This is just an example to show that because I'm just talking as overview, so there are patients with neuro problems, there are patients with physical problems, patients, a lot of problems. So what we do is we can use medications to treat, let's say for anxiety and depression, relaxation therapy, all this robotic, and even patients who are, who is unable to be very active, to go to the gym, we have a few equipments that they can use while they're on bed. Okay, so that we make sure that they start early on and early rehab and evaluation. Okay, so again, I have to mention that the team or the backbone of this return to work program in UMMC, the main are all the occupational therapists who are specialized in return to work, but they also the same team who are also looking at driving as well, because you will see that return to work and return to drive are somehow connected with each other. So this I only have old pictures, but there's a team in 2019 with the SOCSO officer there. And besides the occupational therapy team, the next important team is, similarly important, are the multidisciplinary team where the doctors are in, the clinicians, the nurses, the physiotherapists are in, the social worker, and all the team, the rehabilitation medicine team. This is just for example because my specialty is in neuro rehab, which, especially in the acquired brain injury. So this is the full team. You can see how big team we are. So during the initial state, this team will be involved together with the occupational therapy team who is specialized in return to work. Okay, so this is just a timeline. If you can see, just an overview, you have an early treatment and rehabilitation where we'll focus on the medical complications and the basic function. This is done in the acute and subacute intensive rehab program. And then work assessment, we'll start to look into looking at the capacity evaluation, job analysis, to look at the detail of the relevant job scope. If possible, the team, the occupational therapy team will, and one or two doctors will also start the work visit, go to the workplace and do a visit. And then we'll start the skills training, work-related function activities, because if the work needs a lot more cognitive activity, then we'll focus more on that as well, while looking into the physical endurance. And we need this information from the employer. So that's why we already start to maintain the communication with the employer very early on. And then there is a trial of return to work. This is a joint return to work planning, which means that when we say trial of return to work, this is already agreed with the employer. We discuss with the employer, we have a meeting at least 1 or 2 weeks before and mention what the patient, the employees, the problems that they're having. And we try to suggest activities, modification or simplification if possible, give them a frequent work rest in between. You don't have to stick to 1 to 2 lunch hour break, or we will tell them no shift work first, just during day work, not night shift or certain things. So we agree with the employer, agree with the employee as well before the return to work. Normally, this is done in the return to work clinic because it's easier to have everybody there. And if the SOCSO is involved, the SOCSO officer will also join the discussion for trial of return to work in the clinic. Then we will do the re-evaluation, which means the assessment post-trial. We have a feedback from the employer and the patient themselves, and to look at job maintenance skill and to make sure that they can sustain in the current job. And this is also, we will invite the employer to come and have a meeting with us, or sometimes they just give us a written feedback, email or something, or the person who will liaise with the employer at this point of time will be the occupational therapist in charge. Okay, this is again just an overview, same what I've mentioned earlier, first engagement during the care and then continue intensive rehab. We assess the employee readiness to work, initiate and plan this program. So we have an employee meeting, provide for this job trial, consistent with the employee's fitness to work, provide clear and accurate current details about the program, seek to reach agreement together, but this is together with all the whole team. This is what has been done at the site by the occupational therapists as well, the work training, conditioning, driving ability. We'll look into this as well. Support them. And then hopefully when they have returned to full, successfully, we will discharge them. But normally we'll discharge about 3 to 6 months after return to work to ensure the sustainability and maintenance of return to work. This is just an example of a photo, the SOCSO officer, the employer, the employee, and ourselves in the return to work clinic when we reach the agreement. We have to be agreed by everybody and ensure that it benefits both the employer and the employee themselves. So the readiness is also important because we will give the medical advice about returning to work at the right time, look at the complication, the clinical condition of patients, and safety at workplace. We also, like I said again, to provide support to both employee and employee. The employers are actually quite understanding, actually, if we do discuss with them. But we have to ensure that we do not disclose confidential issues or information. Sometimes we will discuss with the employee first. Normally, what do you think you want your employee to know? Because there are certain things that employee don't really need to know. But I think the related that's related to operational matters, employer needs to know, and we have to also advise the employer, the patient, that we will have to disclose certain facts. Yeah. Okay, job hierarchy. I think just now Dr. Tania also have shown the results of your pilot study, which means that the first is actually same employer, same job, same employer, similar job. This is when you have a different title. Just now, I think a different title, meaning that you have a similar job, not the same as before, but probably lower rank. So that's why it's similar job, different job with the same employer. The next hierarchy will be different employer, same job as before, but different employer, similar job, different employer, different job, different employer. Those are the hierarchy of the job return to work. And what happened to if these patients do not fit to return to work? This is one of the example where the team will try to see whether we can do a work resettlement to find other places, a suitable job within the community base, or the team will try to help liaise with the SOCSO or anybody, the EPF, to ensure that the employee will get benefit, like the appropriate benefit. So this is but this is in the old data. We haven't done the more recent data. Is 2015, looking at our return to work clinic. But only for amongst the neuro rehab patients, because at that point of time, majority were from the neuro rehab, and because my specialty is also with neuro rehabilitation brain injury. 71% actually successful to return to work from the clinic, only from the clinic data. 75% of them be able to return to work without any modification, and the factors associated with successful return to work were pre-morbid income, depending on whether they are in which band of income. But I think this is also related to the type of job as well. Time to first enrollment for the return to work service or program, ethnicity and socioeconomic background. These are just the factors, but we just presented it in one of the conference in 2015. And I suppose at the end, it's just to look at how to close the gap. And I think the gap is it has to be from different angles, from multiple angles, from the clinician angle, from the employer angle, from the employee itself, and also the legislation. But I think what we can do, what we are in the pipeline, is that from the clinician point of view, from rehab medicine itself, we are trying to establish this cancer rehabilitation program and cancer rehabilitation service to make it more multidisciplinary, make it more structured, and to strengthen the how of this referral, and to ensure this return to work program is available to all the cancer survivors as well. So I think with that, I thank you.
Thank you, Prof. Mazlina. Thank you for that very nice overview of what is available. And, sometimes cross-pollination can happen, right? So we hope it can happen in the future. And our next speaker will probably answer some of these questions in a way on how to cross-pollinate across the different multi-sectors. Associate Professor Dr. Julia Patrick Engkasan is our former head of department in cancer rehabilitation in Faculty of Medicine, and she also is the former chair of the I think you only count by it, so a former chair of the National Conjoint Board, and her area of specialty is actually spinal cord rehab and research ethics. So without further ado, Julia, go ahead. I think you're muted, Julia.
All right, so good morning, everybody. Thank you, Aisha, and thank you for all those attendees who come to this breakfast at UMHealth this morning. What I'm going to do now is to share with you a project, an ongoing project that we are doing in our effort to reduce the care gap for cancer, specifically breast cancer patients, right? So So the title of my presentation is Exploration of Needs of Patient Health Systems in Implementing a Breast Cancer Survivorship Care Plan in Malaysia, and the acronym is ENPHaSIS. So I am representing the group of researchers from the IIRG grant. So we have, of course, Prof. Aisha, Dr. Tania, Prof. Nimala, as well as our KKM stakeholders are all in this project. So I'm going to talk just a bit on cancer survivorship. So cancer survivors defined as people living with and beyond cancer. There has been a bit of discussion on when does survivorship start. There are some thought of school that it should start when the treatment ends, but for our project, we include those who are undergoing treatment. So this is acute, extended, and permanent. Acute is from diagnosis to treatment of cancer care. Extended, there's a time period, but it varies and can be up to 10 years. And for a permanent, it's roughly equivalent to cure, and it is usually after 10 years. And survivorship is a key component of the cancer care continuum and includes issues related to ability to get healthcare, follow-up treatment, the late effect of treatment, second cancers, and quality of life. In 2006, that was roughly 16 years ago. So I introduced these components of cancer survivorship, which include these 5 domains, right? So it's surveillance for cancer recurrence or new cancer, management of symptoms that persist after treatment ends, and evaluation of risk for and when possible prevention of late effects of treatment. Because most of the time we think about radiotherapy, chemotherapy, ongoing treatment, and ongoing treatment effect. But later on, people realize that even after years of years after you complete your treatment, you can still have late effect of treatment. Then that was quite evident when they have problem to return to work despite being despite they have completed their treatment. And assessment of psychosocial needs and provision of appropriate support, because psychosocial needs actually extend way beyond the treatment. Because, for example, if there is disfigurement, there is effect on your economic sufficiency, you will have some psychosocial effect on the patient and their family. And counseling on patient on lifestyle modification for prevention of cancer-related morbidity, mortality, as well as to improve quality of life. Because I think in the previous long time ago, cancer is something that's not curable. So, right? So you're scared that being active, because the sick role you remain sick and inactive. But things have changed now because of the better treatment modality that we have. And the important statement that is also in this statement by our M is that quality of survivorship care measure should be developed through public-private partnerships. So it should not be done in alone. You have to have consumers' contribution to it, involvement or engagement to this. And coming back to the breast cancer in Malaysia, because this is the project is all about is on a breast cancer survivorship plan. So I think this is nothing new. Breast cancer is the most common cancer and accounted for 34% of cancer among female in Malaysia, and the survival rate is 5 years 68%. And we all know that due to improved diagnostic and therapeutic effects, survival rate has improved. And as the breast cancer population is growing, the focus now have shifted towards better survivorship care, right? And breast cancer survivors often experience long-term treatment complication, living with the risk of cancer recurrence and other complications that require supportive care. And specific to breast cancer survivorship care, these are the components that was reported by Zujewski in 2017. There are 7 components. So there are some similarity and some different from the domains that IOM reported earlier. So first is monitoring of breast cancer recurrence, managing long-term treatment-related complication, optimizing health through lifestyle, providing psychosocial care specific to survival issues, providing information on financial support, providing information on genetic counseling, and also a well-established referral system, communication, coordination of care, right, to help patient transition from oncology care to follow-up care. And what happened in the Malaysian landscape, right? So in 2016, in the publication 2016-2020, the elements of cancer survivorship was an agenda in this report, but it is not mentioned as cancer survivorship program, right? But then in the latest publication in 2021 to 2025, there is a section just on cancer survivorship. So the aim is to reduce disease mobility and mortality and to improve quality of life of patient and the family. So even in our Malaysian landscape, cancer survivorship have gained importance. And let's see what is being laid out in this 2021-2025 publication. So this is the appendix, right? This is from the latest publication. And you can see here what are the objective, strategy, action, performance indicator, target, as well as the collaborating agency. You can see that it is very quite specific to rehabilitation that explain the presence of me and Prof Mazlina in this talk. Right, so there is an effort to provide cancer rehab services to patients who need and benefit from rehabilitation, to establish a national consensus for cancer rehabilitation services. Right, and the next focus is, vocational rehabilitation, to provide a pathway for vocational rehabilitation, aim to empower financial independence and improve the quality of life of cancer patients as part of tertiary prevention of cancer. Right, so it is included in the national program. So it is really time for us to all work together to ensure that the cancer survivorship plan in Malaysia works for our patient. But then, it is not as easy to implement, even though I can see that there are already plans, but this is the next 5 years plan. There are barriers to providing high quality patient survivorship care, right? Because there is a need for trained personnel, limited financial structure, and lack of integrated healthcare system. So this has been highlighted, and if you are involved in caring this patient, that there is a problem, there is barriers, right? However, we know that we have existing resources that could be used and rearranged to provide this cancer survivorship plan. So in order to implement high quality survivorship care in Malaysia, it is important to study the needs for cancer survivorship care in the perspective of cancer survivors and health system. And this is what our project is all about. So this is how this project is initiated. And like I said, the patient, for this group, we are concentrating more on the health system, right? Because there's another group doing the needs of patient. Right, so this project aims to develop a health system needs assessment questionnaire for survivorship care, to identify the needs of health system and healthcare providers in implementing survivorship care plan, and to estimate the budget required to provide the relevant services. So for the first one, what we did is to develop the health system need assessment questionnaire. It was planned for March 2020. Actually, it's supposed to be a physical workshop, but unfortunately, because of COVID, we have to do it online. So we do a Delphi methods. And right from the start, the researcher identified 5 domains. These are the 5 domains: psychosocial lifestyle modification, financial, cancer rehab, and genetic counseling for the survivorship care plan in Malaysia. And we involve the healthcare providers. You can see there, these are the list of different specialty that we involve in this health system needs assessment questionnaire development, right? So a whole lot of different discipline. We also involve consumers, has been recommended by the IOM. We have cancer survivors, but those who have only those who have completed their treatment. And also we have NGOs, specifically Pink Ribbon Center, NCSM, and BCWA. So for each of these domain, we select around 10, a mixture of HCP, consumers, and NGO to answer the question in specific domains, right? So we choose the appropriate participant for each domain. So in the first round, it is an open-ended questionnaire. So it's mainly asking this question in the specific domain. So what is the perception of patient needs in cancer rehabilitation? So it is an open-ended, so they will write down their answers, right? So all of them, we have the same question, right? The same question in their own domain. And once we have the answers, what the researcher does is to extract what are the components, develop questionnaire, and go to the free round 2, where we ask the participant to rate the importance. It's not to answer, for example, this question. It's not to answer the question, but to rate whether is it important to have this questionnaire in the needs assessment questionnaire. So also the same concept, we choose a group of participants to answer specific domains, and they rate whether which one is important, which is not important. Once we get the answers, so all right, so these are the participants that we have, roughly 40 to 50% of those invited responded, right? And we have a serious discussion among researchers on, on the choice or the question that should be included in the final round of the questionnaire. And after a series of discussion, we end up with this breast cancer survivorship health system needs assessment questionnaire. And from the 5 domains, it became 7 domains. So these are the domains, the 7 domains in the breast cancer health system assessment questionnaire, right? And these are the example of it, right? And question range from 13 to 78 depending on the domain. So those with so there's one domain with a total of 78 questions. So because according to, we look into which domain actually care the most at this point of time for breast cancer patient. So this is an online questionnaire. We developed it, online system, for the participant to answer. So the next round is actually I will do just a brief on patient needs assessment questionnaire is done by another group, all right? So they employed a slightly different methodology, but by the time that we start our project, actually they already have the questionnaire. So it's only about validating. So this group already have the patient questionnaire needs assessment, right? And next is to use the questionnaire to assess the needs of patient health system assessment. So we have 2 questions ready, and we perform the questionnaire in these 4 hospitals, right? So UMMC obviously, Heshta, Putrajaya, and Selayang, because these are identified as the hospital who have a lot of breast cancer patient, right? And we have representative for the health system assessment. We will have health professional representing all the 7 domains actually from each hospital to answer the questionnaire, right? And what we want to see what is happening now, because only when you know what's happening now, then you know what you need to do, and what would be the appropriate framework for this for breast cancer survivorship care plan in Malaysia. And in parallel with this, the patient assessment is also ongoing. So we have started this phase 2 where we for the health system, we started with UMMC first, right? So we have distributed the questionnaire to the healthcare professional and to see whether the system, because it's the online system, the system works well, and whether there's need, then the questionnaire are clear. And subsequently, we'll go to the 3 different hospitals. So if you notice, these are the different type of hospitals, different setting. One is the teaching, one is a state hospital, and one is a major district hospital. So to see what is the current situation in different setting of healthcare. We don't have the result now because it's still ongoing. And the next phase is to develop the breast cancer survivorship care plan framework or model. So once we have the result of what's happening now from the phase 2, we will have to meet together with our researcher, with our KKM counterpart, and also the breast cancer NGO, and see the result and how to develop a framework for breast cancer survivorship model in Malaysia. And at this point of time, we really don't know whether it's going to be online or physical, right? So the next phase to discuss. And also we have a member in our group who will do the financial budget, because this is always a question: what do you need, to develop this? After we had a framework, what do you need to implement this framework? So we have Dr. Fatiha, who will do estimates the budget needed if we were to run this the proposed framework in Malaysia. And we hope that we will come up with something like this. This is from Australia. This is cancer in general, right? So they have actually it is only a 2-page document, but it is quite comprehensive, where the principle as well as the expected outcome. And on the right side is a framework for prostate cancer survivorship program. So we hope that at the end of our project, we will have this to document to be proposed to the appropriate authority. Right. So hopefully that with this project we are able to make the journey for our cancer patients, especially breast cancer patients, more meaningful and improve the quality of life. With that, thank you very much.
Thank you, Prof. Julia. So I think we are about to open up as a panel. So may I also invite the two panelists who is joining us today. We have Dr. Mazlan from SOCSO. He's a public health specialist and occupational health physician, currently heading the Prevention, Medical and Rehab Division of the SOCSO, or Social Security Organization of Malaysia. And he is also an examination board member of the National Institute of Occupational Safety and Health, and also curriculum committee member of the Faculty of Medicine in UM. So you're actually also wearing a hat in UM, Dr. Mazlan. And the other panelist that we have today is Prof. Victor Ho. I think we don't really need to introduce Prof. Victor Ho. He's been a very instrumental voice during the COVID-19 pandemic. He is now the head of department of the Social Preventive Medicine Department. He is also an occupational health physician. He has also been in Turin, so maybe later we can discuss about that. So let's open up the panel, because I think we have actually sort of skimmed over the issue of return to work in cancer survivors. Thank you, Prof. Julia, for at least giving the definition of the cancer survivor. And we realized that cancer survivors are heterogeneous in group. And I think Prof. Mazlina mentioned that the challenges of providing a program for a heterogeneous group is actually quite challenging, right? And there were issues about policy of sick leave, paid leave, and so forth. So let's open up the panel. Maybe we can start off with Dr. Mazlan to sort of maybe give an overview about the role of SOCSO in providing return to work programs. Is there any cancer survivorship sort of return to work programs available for people? And maybe later, Prof. Victor, you can just chip in anytime and give an overview about what does the occupational health physician, their role in the clinic, and how we can bridge the gap between occupational health physicians in the occupational health clinics, the cancer clinicians, and the rehab physicians. Okay, so let's start with Dr. Mazlan.
Thank you, Prof. Aisha. Can hear me? Right.
Yeah.
Okay, thank you for the opportunity. First, before I start about SOCSO, I just want to appreciate Professor Mazlin's first slide on why why the cancer-related patients needed to return to work. And out of those 6 reasons, actually there's only one reason of financial reasons. The rest are all about the well-being of the persons, and that is really something that we've been talking about when we started our own return to work program, not only for cancer patients, but all injured patients or injured persons. That's how we call them. Anyway, it is not really about saving money or about SOCSO being able to not pay their pension or whatnot, but it's really about their well-being and their role in the society. So when we started this return to work program in 2000, in 2008. It was really was open when we started. It was open to mostly injured persons and also those who are claiming for invalidity. But then when we enhanced the program, we provide more and more services for the return to work program, and this was again highlighted by both Prof. Mazlin and also Dr. Lydia just now. As you can see, we are quite involved in the return to work program in UMMC as well. There are, although Prof. Aisha, to answer your question, we do not have a specific cancer return to work program, but the cancer patients are included into any of return to work program that we are doing for the whole country. And based on what I have gathered from our team, unfortunately, the numbers of cancer patients who are enrolled to our program is not as many as we would like it to be. In fact, from 2016 to 2021, so that's a 5 years program, we only have 65 insured persons who actually enroll to return to a program who are with cancer, compared to thousands of other patients that goes into the program. And unfortunately as well, although we think it is a success, but maybe we would like to have more success, only 17 of them were able to keep their jobs, and the rest are not able to return to work despite enrolling into the program. And there is really some issues, and I'd like to look at the gaps that was presented just now that still needed to be handled. One of the most important gaps, I think, was that this was also related by the team, is there is a lot of focus by our insured persons to get the pension scheme. So they have the mindset that they should get the pension, and once they get the pension, unfortunately, maybe motivation, psychological issues comes in, that returning to work is no longer a priority. So that is something that was highlighted, and this is a very difficult issue to address, really, because most of the patients, when they come into the program, they are in the situation where they are not yet invalid, but they've already lost their source of income because of the loss of job, or even when they are on leave, they are now on unpaid leave. So in that situation, it is really a chicken and egg kind of situation, because if we put them into invalidity, then your return to work program will be jeopardized. If you don't put them into invalidity, they will also have a problem. So I think that there is a one gap that we might want to think about, instead of because we are looking at the biopsychosocial model. I think the biological part, the treatment, also done well by the clinician, and then we got really good social support, the physical rehab all done. But that big gap on compensation and claims experience is really something that we think is a gap that we can look into, not necessarily from our organization, but from any other sources to try and see how we can then have the clear pathway of from being diagnosed, treated, complete treatment, rehabilitation, and then back to return to work. In terms of our programs, was highlighted earlier, but yeah, we are not, of course, we are not the clinicians who treat the patients, but we provide as much support for the rehabilitation, the occupational therapy, the job placement into our program. And this includes the physical rehabilitation that is required.
It's 9 o'clock.
Sorry, that was me.
It's really nice to see the rehab ward in UMMC, but we also have our own rehab center that can be utilized by the patients, not necessarily in Malacca. We also have satellite centers in KL, in Penang, and a few other states as well. So those are things that can be utilized for their convenience. But most importantly, the case management. So our case management there to help And it's their role really to link up the rehabilitation process and later on with the work relationship, the job placement process. And do not forget that we also provide the training, so and retraining of all insured persons, including cancer, if we require them to be working in a different role. But then it all comes back whether we are going through the process of return to work seamlessly, and they are continuing to progress. It's just, I think, the most important thing, again, back to the first thing that I said, it is all about the well-being of the person, and we want them to be back as a member, as a producing member or productive member of the society, and that is the most important for us, really.
Okay, thank you, Dr. Azhar. I think what you put it, like right on the nail, head of the nail, is that the issue sometimes people look at it also as just get a pension and not really looking into, as you say, getting back to the quality of life. And it's really not wonderful to know that these satellite centers are all over Malaysia, and that could be accessible to other patients around the country. So back to Prof. Victor, maybe Prof. Victor, what do you think? I mean, like right now you can see that we have different resources in different departments. What would be, in a way, a suitable way to sort of create a referral pathway, to getting people who are cancer patients, who want to address their return to work issues? What would your comments be?
Thank you very much, Prof. Aisha, and I think Dr. Aslan actually have painted a very good picture, and of course the other speakers also painted a very good picture. The thing about return to work, as we know, is a multidisciplinary issue. It's not an individual issue. All right. You need to look at it from a multidisciplinary perspective. So occupational physician is one of the linkages between work itself and also medical itself. So the psychosocial model where we talk about medical intervention and also medical rehabilitation. But the point is that I think the occupational physician would be also have a perspective of what is work. Of course, I know our rehabilitation physician are basically very good at coming up with return to work issues, but I think working together would make it a better model of doing it. And my Dr. Faiz Baharudin actually is basically working with the sports physician to actually look at musculoskeletal disorder as return to work, and how do we improve that on return to work. So, but that is that we need to move forward, and I think this is a very good discussion here today.
Yeah. So I mean, I think it's very interesting to know that at the moment we don't have a framework, right? So I think that's why Prof. Julia was trying to address the issues through that research that we are trying to do, to sort of look at the gaps and then see through multidisciplinary input how we can put the blocks together, right?
Yes, true.
Yes.
Basically, I think there's not just research, but the research should be based on applied research, and how to actually improve the health of the individuals, not just asking them what do they want. I think some intervention research would be good, and I think there's a lot of intervention around the world that has been used already, and there's a lot of models that has been suggested about how to improve that model, and how to ensure that we work together as a team, not just the rehab physician, but also the occupational physician, but also the clinician actually managing the patient. As you understand from SOCSO perspective, and they have basically case manager who basically come in to actually address the patient straight away if there's an occupational accident, and they start from the day one. So a lot of the time we don't start from day one thinking of them going back to work. We only look at them from the perspective of managing their disease without looking at it, what to do after they are cured, what to do if they have this disability, what to do. So all those things are not discussed early, and that is why That's why there's a hiatus, and the patient just don't want to go back to work because they don't feel connected to their workplace anyhow. So the connection to the workplace should be maintained and should not be divorced when you become a patient. And that I think is something that we can do, especially in the case of cancer treatment, which is basically a very prolonged process, and some people just get off the system. When they get off the system, they don't want to go back to work. I mean, from what Dr. Aslan said is correct. Money is one of the main component. But as we pointed out, money is not why I work, not why most people work. It's the connection that makes people want to go back to work.
But I suppose, I mean, if you look at the data, it looks like from the MyBCC study, it's almost like 1 in 2 of the working women actually return to work. But what Dr. Azlan says is like almost like 1 in 3 in the program actually successfully get back to work. I think the international literature is something like 1 in 4. So maybe we're not really getting the whole story lah, the local story about return to work. And a lot of issues sometimes is with temporary workers. So I think Prof. Sarah actually mentioned something in the chat just now to ask about temporary staff has a higher chance of being sacked after cancer. So maybe we can just, if anyone could just comment about what are the rights of a patient. And I think that Tania actually mentioned this. There is no real policy about long-term sick leave. Even like the government, they give. I think the Malaysian government actually is one of the best employers because they can provide fully paid leave, right? But for the private sector, it may not be very clear about what are the rights of the patients. Anybody can comment on this?
Basically, there's no private sector. There's no true rights of the patient. There's only the Employment Act. Employment Act only covers people who's basically earning, I think, less than 3,000 ringgit. If Aslan can correct me if I'm wrong. And that basically other than that is basically on a contractual basis. So you depends on your industry and what's your industry standard. So some industry have a higher standard compared to other industries. So I think what the law says is basically 14 days of sick leave. That's the only thing that is there. So anything more than 14 days is not considered. But you look at government also. Government, the maximum leave you can take is 45 and plus 90 days. 90 days. After 90 days, then you'll be considered, and then you need to be half pay leave. So there are other issues also with government employee, and all those things are basically what we look at it from the perspective of employment, what is needed, and as a country, what we need to move forward, and of course we need to look at countries who are basically doing very well, especially the Scandinavian countries, and how they actually treat their employees.
Professor, I just want to add on about the government servants and the people in the private companies. I think in 2018, one of our staff, academic staff, Prof. has actually published paper regarding the survivors of the breast cancer survivors and looking at return to work factors. And if I'm not mistaken, the result is that one of the strongly associated with return to work is if you are a government servant. At least that is one plus point, I suppose, for us government servants, but not so great in the private sectors, because private sectors have a negative association with successful return to work among the breast cancer survivors. So I think a lot need to be done there. We need to have like some sort of like a guide. So I assume it's not that they don't want to retain their employees, just that they may not know the implication when you listen to that. When people's perception, when you just have cancer, they just say, okay, cancer, that's it. You're not going to live long. Yeah. So those are just common misperception.
Yeah, agreed.
It'll be interesting to know from Dr. Tania's presentation just now. Because I couldn't see this type of cancer or the stage of cancers with return to work among those who return to work. We always have this dilemma in SOCSO as well, because if you have a low stage of cancer with stage 1 or stage 2, and the expectation is that after treatment, you are going to be treated and then you will be back to sort of normal self. in a period of time, and that's when the issue comes in. Because regardless of stage 1 or stage 2, the treatment is going to be prolonged, and you are going to be losing your income at the time. If you are in a private sector, to answer Prof. Sarah just now, especially if you are temporary worker, because they don't have to sack you, they just do not have to renew your appointment or your contract if you're on a short-term basis, right? Running sambilan is 6 months basis, so you just don't have to renew, and that's it. So there is the gap. I think that support is the gap that we need. We tried to put that gap in our job allowance that we give to the patients. To our return to work participants, but that's not enough. But that's what we can do at the moment. There's another thing that we might want to look at is just look at other sources or other ways to do it. For example, for us, we might want to look into, especially if you are contributing into the employment insurance system, then that loss of job can help for a few months. If you're in a return to work program, that can be something that can be looked at. But in terms of for long-term non-work injury or non-communicable diseases such as this, that gap is there, and it is not being addressed anywhere really. And it's just not for cancer; it's for a lot of other diseases as well.
Maybe I can ask a question to Prof. Aisha. Do you go and discuss with employer about the treatment, not just the patient? Have you?
I think you see, when I heard about what Prof. Mazlina said about how you communicate with the employers, this has never been done on our side, because I think, unfortunately, I don't think we even have time to even go into the details.
True. You will not have enough time to do that. So we have a dedicated clinic just to do that, because it's not easy. It's not easy.
But you see, the thing is about awareness. So I think not many clinicians actually know there is such a program, because and patients complain about this, but this is not as what Dr. Azlan says, the biopsychosocial model is not present, when doctors are treating patients. So we don't look at their life as a whole. So we usually say, okay, I just give you MC, and then we because we don't understand. I think a lot of clinicians are not aware about what they can and cannot do in terms of helping patients to get back to their normal pre-morbid state. So that is why I think the cancer rehabilitation referral pathway would be so important, because we have many players in the whole management of the patient, but we don't have this section, Even let's say occupational therapists managing the awareness that there is actually a program that we can refer to, and the awareness among the patients themselves, awareness among the clinicians themselves to refer. So this is the question: when do we refer, right? And how do we refer? So this is, I think, what needs to be sorted out. I don't think we have the answers today, right? And I think we're just beginning to talk about cancer survivorship in Malaysia. We hope that we can sort of jumpstart it. Hopefully this 3-year campaign of closing the gap will be achieved. You see, you need a 3-year program. Or sometimes we say that when you do a national cancer control program, it's not a 5-year program. It's actually a 30-year program. You need to look that far to get somewhere. So maybe we're just beginning to talk about it. And hopefully with enough evidence, enough data from the research, we can provide that sort of guidance on what directions to go. But I'm so happy that we all know that the NCC, the National Cancer Strategic Control, Implementation of Cancer Control, that what Prof. Julia showed just now, actually has included cancer rehab as one of the strategies for cancer control in Malaysia. So that itself, I think, is something very wonderful for our country. And I hope that we will spread the word. And I think SOCSO definitely has a major role in this area. And all of us should really start adopting, looking into the holistic care of the patient, and we cannot do it alone. Okay, like for us surgeons, we like to do a lot of things on our own. Unfortunately, we have a lot of other colleagues that can do this better. So we should refer if we can. And okay, let's just go around the room because our time is almost up. Let's just have last words. Tania, what is your wish to close the gap? Kesian Tania, terperanjat.
Actually, I want to know the employer perspective also as well, because our study cannot capture, but what especially the private sector, the employer thinks, and how we can fulfill the gap, or clinician, how they can address these issues. That's my wish.
Okay, Prof. Mazlina? We just go around the table.
Okay. As someone who's so used to working in a team, in a multidisciplinary team, and know each other's right and role, and really appreciate that, I think that is one way I'm looking at closing the gap, where how to utilize that expertise to bring people together, hopefully, so that everybody understand their role, be it just the clinicians or together with the employees, and their families as well. So I think that the family will be bigger. That's it. I think to close the gap. All right.
Prof. Julia.
Well, my wish is that the framework that we propose and develop will be in that book in the next edition.
Okay. A lot of policy issues, right? Yeah. Prof. Victor, anything?
I think basically the main thing is to work together, and of course we got to talk to each other. The more we talk to each other, we learn more about things that we can do together. And for the patient itself, we must look at it not just from the disease perspective, but also from the social perspective, where we miss it. I think our clinician moving forward should look at it from that perspective. Thank you.
Thank you. Okay, Dr. Azlan, you got the last say.
Right, thank you. Last words, right? I just want to say we are not really that far behind. There's a lot of things have started. UMMC, please use Prof. Mazlina's return to work team. That looks fantastic, and use us as well. Use SOCSO now that we are already also the labor market provider for the country with My Future Jobs and all. Our linkage with the employers are even more on steroids. So there's a lot more areas that we can look into. So we are not that far behind. There's more to do, but yeah, use what we have now, really.
So thank you so much. I think we have enjoyed that discussion very much, and this is just the start. So as we say, this is a 3-year campaign to close the cancer close the cancer care gap. And so hopefully all the listeners, for young researchers, young practitioners, please be motivated to take up this topic, because this topic is really hot and has a lot of future. And at the end of the day, as what Prof. Victor say, whatever we do must have impact to ourselves. Global health is actually local. Okay. All right. With that, I thank you. And hopefully we see again each other maybe in a year's time with better things to talk about. All right. All right. Assalamualaikum. Thank you, everybody. Shall we stay for just a photo? And that's the end of the day today. Thank you very much.
Thank you, everyone.
Okay. Don't leave.